I'm Dr. Fakir Rabari, and this is Observational Studies. In this topic, we will focus on cohort studies and case control studies. Keep in mind that while cohort studies can be either prospective or retrospective, case control studies are always retrospective. Please pause this video and review these definitions. When looking at the quality of evidence hierarchy, note that cohort studies and case control studies are lower quality compared to non-randomized control trials and randomized control trials. So observational studies in general have lower quality of evidence than experimental studies, which have lower than critically appraised studies such as meta-analysis and systematic reviews. The first learning objective is interpret clinical and surrogate endpoints used in observational studies, which is the course learning outcome number 4 on the course syllabus. In clinical studies, when we say risk, we're really talking about probability or likelihood of an event occurring among all. Now imagine we have two groups. We have group A and group B, and there are 100 people in each group. So the n is 100 in each group. And imagine we're looking at the number of people who are dying. So death. And let's say 10 people died in group A and 20 people died in group B. So when we talk about the risk, so the risk of death would be 10 out of 100 people in group A. So 10% is the risk of death in group B, and 20% is the risk of death in group B. And then we also have the concept of relative risk. So the relative risk would be the ratio of the risk. So if you're comparing group A to group B, it would be 10% divided by 20%, which would be 50%. Now, when we look at the concept of odds, odds basically refers to the probability of a particular event occurring as opposed to the probability of that particular event not occurring. So if 10 people died here, the remaining people are alive. So we can say how many people are in group A are alive. So that would be the remaining 90 people. And if 20 people died in group B, that means the remaining 80 people are alive. So now we can actually calculate the odds of dying in each group. So in group A, the odds of dying is 1 to 9. And in group B, the odds of dying is 2 to 8. And of course, we can also do an odds ratio. So it would be, again, the ratio of A to B. So it would be basically 1 to 9 is the odds in group A, and 2 to 8 is the odds in group, which is 44%. Another example to help you understand odds better is, imagine you have a die that has 6 faces. Now, what is the probability of rolling a 4 on a single throw? So because there are 6 faces and only 1 4 possible, the probability of rolling a 4 would be 1 out of 6. Now, what is the probability of rolling a number other than 4? So because there are 6 faces and 5 possibilities other than 4, then the probability would be 5 out of 6. Now, when it comes to odds, we no longer use the number 6. So the odds of rolling a 4 on a single throw is, because there are 4 and 5 numbers that are not 4, it would be 1 to 5. And if the question is what are the odds of rolling a number other than 4, so because there are 5 options other than 4, it would be odds would be a 5 to 1. Now, when interpreting the odds ratio, we kind of interpret it just like a risk ratio. So if the odds ratio is less than 1, it basically means that the odds have been decreased, which typically shows benefit. And when the odds ratio is greater than 1, it typically means increased odds, which would mean increased harm. And because we're talking about ratio, if the odds ratio is 1, 1 would basically mean there are no difference between the groups. Now let's take a look at an example. So this is the results from a randomized trial of endoscopic sclerotherapy compared with endoscopic ligation for bleeding esophageal varices. So let's just call the ligation group Group A and sclerotherapy Group B. As you can see in the ligation group, 18 people died and 46 people survived, which adds up to 64 people in that group. And in Group B, there were 65 people and 29 of them died and 36 survived. So if you were to calculate the odds ratio, so first we look at the odds in Group A. So we would say the odds in Group A compared to the odds in Group B. So in Group A, the odds of death would be 18. So 18 people died to 46 people who did not die. So 46. So instead of 64, we're going to say 46 because those are the people who did not die. And then the odds in Group B is 29 to 36. Which would mean 0.39 divided by 0.8. Which is 0.49 or 49%. Now, if we were to do relative risk, because risk is the probability, it's calculated a little different. So in Group A, it would be the risk of death would be 18 out of 64 people, and then in Group B, it would be 29 out of 65 people. Which would give us 0.63 or 63%. So you see, you get different numbers whether you calculate relative risk or odds ratio. Now, regardless of whether there is odds ratio or relative risk, when it comes to number needed to treat, you have to use the risk difference. So it doesn't matter if they got relative risk or odds ratio. Regardless, you have to get the risk difference. So the risk difference here would be 0.455 minus 0.28, which is 0.165, and then the number needed to treat would be, by the way, this is equivalent to 16.5%. So then the number needed to treat is 100 divided by the absolute risk difference, which is 16.5%, which would give you 6.06, which you always round up. So this is 7. Now, here are a few things that you should know about odds ratio. So cohort studies and randomized controlled trials can either report relative risk or odds ratio. Now, however, case control studies can only report odds ratio. So if you see a case control study that gives you relative risk, they've conducted the study inappropriately. So it should always be odds ratio. And also, when you look at regression analysis results, they will also report odds ratio. Now, as I showed you before, the calculation for odds and risk are different. So now let's compare the odds and the risk. So as you can see, when the risk is high, there is a big difference between odds and risk, whereas when the risk is low, the difference is small. So I've done some sample calculations for you here. So when the risk is 0.05, when you convert it to odds, you can see the odds are 0.053, and the equation is down here. And this is just to show you the concept. You don't really have to do these calculations. So you can see when the risk is really small, like 0.05, it's close to the odds. As the risk increases, you can see that these numbers start to deviate from the risk. So in fact, once you go, past 0.5, it really becomes a huge gap. So you can see this is twice as much. So a risk of 0.5 is half of the odds of 1.0. And when you go to 0.6, 1.5, 0.8, 4.0. So what I'm really trying to show you is that the odds ratio will always make a treatment appear more effective than relative risk. Another thing that you should also keep in mind is that while randomized controlled trials can demonstrate causation between treatment and outcome, causality cannot be established in observational studies. So when you look at the results of observational studies, it can only show you association. It can never establish causality, which is extremely important to keep in mind when you interpret these odds ratios and relative risks. And of course, when it comes to statistical significance, we do the same thing with 95% confidence interval. You use a p-value to see if the odds ratio is statistically significant, or you can use the 95% confidence interval, and as long as the confidence interval does not include 1, because 1 means no difference, then you can conclude that the results are statistically significant. Now let's take a look at the example. So this study was published in New England Journal of Medicine in 1997. So they basically, this is a case control study. They looked at healthcare workers with occupational percutaneous exposure to HIV infected blood. So basically people who, accidentally poke themselves with an infected needle. So they want to see how many people will actually develop HIV. So as this is a case control study, they started with the outcome. So the cases are people who had the outcome. So these are the people who actually became HIV positive, and the controls are people who did not have the outcome. So these are people who did not become HIV positive. So in this table, so again, these are your two groups. The case are patients who developed HIV, and controls are people who did not develop HIV, and everybody accidentally poked themselves. So now they're looking at they're doing multiple analysis. So the first row, they're looking at the size of the needle, and then they're doing giving you the odds ratio. So you can see if they poke themselves with a large needle, the odds were actually 14, and it was statistically significant. As you can see, this is the confidence interval goes from 4.9 to 39. So it does not include 1. The entire confidence interval is to the right side of 1, which is the line of no difference. And the p-value is consistent, so it's statistically significant. If after exposure everybody receives zidovudine, which is a HIV drug, you can see that it made no difference between the two groups. So meaning that the patients were not at increased odds of developing HIV if they receive zidovudine. So you can see the p-value is statistically insignificant, and the confidence interval includes 1. So this goes from 0.3 to 1.4. So the 1 is actually included in the middle between 0.3 and 1.4. We looked at interpreting endpoints of observational studies. Now, let's determine the type and strength of correlation between two variables, which is the course learning outcome number 4 on the course syllabus. When it comes to clinical studies, clinicians are interested in 3 sorts of questions. We want to know if there is a relationship among different measures or variables, and for that we look into correlation. We also want to know if we can predict individuals at high risk of having a subsequent event. And for this, we look at predictions. And of course, we're interested to know if there's a causal relationships among biologic phenomena. And for this, we look at causation. Correlation is the degree of association among different variables. Now, if we want to describe the relationship among different variables and predict value of a variable based on another variable's value, we use a technique called regression. Let's take a look at correlation first. Correlation is essentially a statistical tool that allows us to see if there's a relationship between two variables. For linear correlation, we typically use the Pearson correlation, and for nonlinear correlation, we use the Spearman correlation. When there is a correlation between two variables, this correlation can be positive or negative. In a positive correlation, both variables move in the same direction, whereas in negative correlation, they move in inversely in different directions. Clinically, we are interested in strong correlations, whether it's a strong positive or a strong negative correlation. Let's take a look at Pearson correlation as an example. While Pearson and Spearman correlations are calculated differently, clinically, we interpret them similarly. So I'm only going to talk about Pearson correlation here. What you need to look for is the Pearson correlation coefficient, which is typically represented with the letter R. And R can range from negative 1.0 to positive 1.0. And of course, a negative 1.0 would mean a perfect negative correlation or relationship, and positive 1.0 means a perfect positive correlation. Now, while there is no guideline to determine at what value the correlation would be a strong correlation, clinically, commonly a 0.8 is accepted as a threshold. So anything, so on the negative side, anything that's between negative 0.8 and negative 1 is considered strong negative linear relationship, and on the other side, positive 0.8 to positive 1 is a strong positive linear relationship. And of course, 0 would mean no relationship. Now, you have to use your clinical judgment. So if it's something negative 0.7, depending on the situation, you may consider it strong relationship. Whereas if it's negative 0.2, because negative 0.2 is closer to 0, it may not be clinically significant. But these are the numbers that, at least in JAMA, it's the JAMA's users guides is recommended. Now, while R will tell you, how strong the correlation is between two variables, you also need to know if it's statistically significant. So we also get the p-value for the correlation. So for this p-value specifically, the null hypothesis is that there, the correlation between the two variables is 0, or basically there is no correlation between the two variables. So if the p-value is significant, we will reject the null hypothesis and then accept that there actually is a relationship. In other words, if the R happens to be 0.2, while we can say that there is a weak correlation, the question is that correlation a true weak correlation, or is it due to chance? And that's why we need the p-value to know if that correlation is due to chance or is it statistically significant. Alternatively, we can also get the confidence interval for the R. So if R of 0 means no difference and we get the confidence interval, so that confidence interval should not include 0 in order to be statistically significant. And the stronger the correlation, the more likely that the p-value will be significant. And also, in addition, a larger sample size will be more likely to have a significant p-value for a correlation. Another concept that's clinically important is the concept of coefficient of determination, which is basically calculated by squaring the R. So because we're squaring the R, we can no longer have a negative number. So the range is from 0 to positive 1. And although there is no guideline, on interpreting the R squared, a commonly accepted threshold is if the R squared is greater than 50%, this coefficient is extremely useful, whereas if it's less than 10%, it's not very helpful. So usually we want to see an R square of at least 50%, which kind of goes along with, if you want your R to be 0.8, if you want the R to be 0.8 to be a strong correlation, then the R square would be, so maybe I should say at least 0.8 would be good. Then the R square would be at least 0.64. Now, to make things easier, we're going with 50. So an R squared of at least 50 is extremely useful. 50%. So this 0.64 is 64%. Now, before I show you an example, let me orient you to some pharmacokinetic concepts so that you would understand the example. So here in this picture, we're looking on the x-axis. We have time in hours, so 0 and then 24 hours, 48 hours, 72, and 96. And on the y-axis, we have concentration of a drug in the blood. So you can see, at time 0, the concentration in the blood is 0. Now, at some point, we're gonna infuse this drug intravenously into the blood. So as we start the infusion, the concentration in the blood goes up. So let's say we infuse this for 1 hour. So after 1 hour, we stop the infusion. So we have infused all of the drug. So now we have a concept of Cmax, which is the maximum concentration of the drug in the blood. And sometimes we call this a peak drug concentration. And because we stop the infusion, now the body starts clearing it. Now, assuming one compartment model, the body will start to clear this drug. So the concentration as time goes on, the concentration starts to go down until it's time for the next infusion. So at this point, 24 hours later, we're gonna give another dose. So now the concentration starts to go up until let's say we infuse it for 1 hour. So you get another peak level, and then the body starts to clear it until it's time for the next dose, so on and so forth. And then, so the concentration right before we give the next dose, that's the lowest the concentration would go. And we call that the Cmin, or the minimum concentration, or sometimes we call it a trough drug concentration. Now, another thing that we can do is the concept of area under the concentration time curve. So which would be like calculating this area under this graph. And so this shaded area is the AUC for 1 dose. If you want to calculate for 2 doses, it will be all of this area as well. So now that we know what's a peak, what's a trough, and what's a AUC, or area under the concentration time curve, let's look at an example. So in this study, vancomycin is an antibiotic. So they were looking to see if there's a correlation between vancomycin trough levels to AUC. So on the x-axis, they are showing you the different vancomycin troughs, and on the AUC, they're showing you the area under the concentration curve. So and these are all the this is a scatter plot of all the values that they got in the study. And then they want to see if there's a correlation between trough and between AUC. So you can see they calculated the R to be 0.437 or 43%. So there's a 43, or let's round it to 44. There's a 44% correlation between vancomycin trough levels and AUC. And as you recall, we were interested in a value of 0.8 to call it a strong correlation. So this is not a strong correlation. In fact, it's worse than a coin flip. So it's not even 50%. Now, if you look at the p-value, you can see that while the correlation is not strong, but it is statistically significant. So you can say that there is a significant, and by significant we mean statistically significant, correlation between the trough and AUC of vancomycin. Now, if you square this, so if you get R squared, you get the coefficient of determination, which becomes 19%. And as you remember, we wanted a value of 50% for it to be extremely useful. And what this means is that, the variability in AUC, or I should say, because the R squared is 19, I can say that 19% of the variability in AUC is explained by the vancomycin trough levels. And that's not very useful because this 19% is very, very low. We looked at interpreting endpoints of observational studies. We determined the type and strength of correlation between two variables. Now, let's interpret the results of regression analysis, which is a course learning outcome number 4 on the course syllabus.
So, if you have multiple variables, you can actually do regression analysis. Now, if you only have one variable in your model, well, first of all, if your variable is continuous, we use linear regression. And if you're looking at dichotomous variables, so let's say mortality, for example, so the variable is either yes or no, for dichotomous, we actually use logistic regression. So here are the two general types: linear regression or logistic regression. And so obviously one variable will always be your dependent variable, and it's just a matter of how many independent variables you want to have. So dependent variable will be your clinical outcome. So let's say mortality. And then if you only put one independent variable, then you only have two variables. So we call this a bivariate regression, bivariate regression analysis. Whereas if you put multiple variables in this, multiple independent variables, then we call it a multivariate regression analysis. So let's take a look at an example. So here in this study, they were looking at basically risk factors for what's the likelihood that someone in the ICU will have bleeding in the gastrointestinal tract. So the dependent variable is bleeding. So that's the clinical outcome. They're looking at bleeding. They're interested to know how many patients, what's the likelihood that patients will have bleeding. So that's your dependent variable, and then all these risk factors are your independent variables. So they can analyze this one by one. So they say, okay, so obviously you have bleeding is one variable, and then the second variable is mechanical ventilation. So they calculate the odds ratio in a bivariate. So this is a bivariate regression. So in the model, we only have two variables. One is bleeding, and the other one is mechanical ventilation. So it was statistically significant. The p-value is very small, and the odds ratio 25.5. Then they did it for the next one. So you only have two variables. So one variable is bleeding. The second one is coagulopathy. This was also statistically significant. Then they did another one for hypotension. So people who had hypotension, that's one variable. The other variable is bleeding. So the odds ratio were 5. And p-value was statistically significant. So they keep doing this for all of these, right? So and they note that they were all statistically significant. So the danger of just doing a bivariate analysis is you don't know if any of these, if you only look at one risk factor, you don't know, how much the other risk factors are contributing. So in order to fix that problem, you do a multivariate regression. In other words, you put all of these variables in the model, and then you analyze one by one. So if you have all of the variables in your model, and then you say, okay, so in a multivariate regression analysis, mechanical ventilation gave me a p-value that was statistically significant, and the odds ratio was 15.6. Now that's important because we also accounted for all the other variables, and still mechanical ventilation was had increased odds of bleeding, which was significant. They also did this with coagulopathy. So in a multivariate regression analysis where it included all of the variables, coagulopathy ended up with a statistically significant odds ratio of 4.3. Now here's where it gets interesting. For the remaining variables, none of them were statistically significant. So they're not even reporting the number. So NS means not significant. So that shows you that it's extremely important to do multivariate regression analysis in order to make sure you account for every variable.
We looked at interpreting endpoints in observational studies. We determined the type and strength of correlation between two variables and interpreted the results of regression analysis. Now let's describe the propensity score matching technique, which is the course learning outcome number 5 on the course syllabus. In routine clinical practice, not every patient gets the same treatment because patients are different. For example, elderly patients may get treatments that are better tolerated, or seriously ill patients may get treatments that are known to be more effective. This leads to a correlation between patient characteristics and outcomes, which we call confounding. And this confounding by indication is basically when clinicians decide what's indicated for a patient based on their characteristics. And because observational studies are basically a reflection of clinical practice without a control group, confounding bias is common in observational studies. Now, the best way to avoid confounding is by randomization. Unfortunately, in observational study, randomization is not possible. So we must rely on techniques to minimize the confounding in observational studies. Commonly, multivariable statistical methods are used in order to account for this confounding or adjust for this confounding. Propensity score methods can also reduce the bias. Let's take a look at what the propensity score actually is. The propensity score is basically the probability that the patient would get the treatment based on their characteristics or based on the treating clinician's preferences or the clinical environment. And these probabilities can actually be calculated, or I should say estimated, using multivariable statistical method. For example, we can use logistic regression. And then once we calculate this propensity score, then we can adjust the two groups to make sure that the two groups are equal based on the propensity score. And propensity score methods are better than other methods. So when you evaluate observational studies, you should look for propensity score methods in the studies. So if they did not have propensity score methods, they already have lower internal validity compared to observational studies that actually use propensity score methods. Now, there are 4 general ways propensity scores are used. The focus of this course is on propensity score matching. The rest of them are beyond the scope of this course. So with propensity score matching, basically individuals are matched with similar or actually identical propensity score. So let's say if a patient is in group A with a certain propensity score, there will be another patient with the same propensity score that goes into group B, and that's how they match the two groups. And this is the best thing we can do since we cannot do randomization. And of course, since this is not randomization, there are some limitations to it. So for example, unadjusted confounding may still exist if unmeasured factors influence treatment selection. And of course, the quality of the matching depends on the quality of the propensity score model. So it's a matter of how many variables you put in the model that you think would actually affect the probability that the patient would get a certain treatment, and whether those variables are available or collected in the study. In general, propensity score matching minimizes bias to a greater extent than the rest of these other techniques. We looked at interpreting endpoints used in observational studies. We determined the type and strength of correlation between two variables and interpreted the results of regression analysis, and we described the propensity score matching technique. Now, given an observational study, evaluate its internal validity, which is the course learning outcome number 5 on the course syllabus. In observational study, we want to make sure that the patients are similar for prognostic factors that are known to be associated with the outcome. Because observational studies cannot be randomized, it is important to make sure that the study is adjust for any of these biases. However, the investigators can only adjust for risk factors that are known and measured. Residual confounding refers to important prognostic factors that the investigators do not know about or have not measured. And residual confounding is something that we can't really do anything about. It's a limitation of observational studies. Another bias that can emerge in cohort studies is detection bias, which is the tendency to look more carefully for an outcome in one of the comparison groups. This detection bias, which is also known as surveillance bias, can be reduced by selecting comparator group patients that are actually similar in likelihood of screening or testing, or by selecting outcomes that are likely to be diagnosed equally in both groups, or by adjusting for the surveillance rate in the analysis. Another bias that can emerge in cohort studies is attrition bias, which is basically when we have patients lost to follow-up. This can introduce bias because the patients who are lost may have different outcomes from those patients who are still in the assessment, and different groups may lose patients at different rates, so the groups will no longer be equal. Case control studies are susceptible to unmeasured confounding, as well as recall bias and interviewer bias. Especially since we're dealing with controls in a case control study. So control are the patients who did not have the outcome. So, when we have these patients in the study, it's a matter of their memory. So when we ask them questions, it's more likely for people who actually have the disease to remember things that can contribute to it, whereas people who don't really have the disease are unlikely to remember things because things aren't as eventful for those patients as opposed to patients who actually have the disease. And the person who's actually interviewing the patient can also introduce some bias. Someone who's interviewing someone who has the disease may ask more questions as opposed to interviewing someone who's otherwise healthy. This table summarizes some of the techniques that are used to minimize the risk of bias, and it compares the clinical trials to observational studies. So some of the techniques that we can use to reduce bias. So far, we looked at interpreting endpoint of observational studies, correlation, and regression analysis. We described the propensity score matching technique, and we looked at evaluating internal validity of observational studies. Now, given an observational study, evaluate its external validity, which is the course learning outcome number 6 on the course syllabus. So once we evaluate a study's internal validity, then we look at the results. If the results are statistically significant, the question is the difference a true positive or is it a false positive? And if it is a false positive, we call it a type 1 error, and we set alpha to 5%. So at most, we tolerate 5% type 1 error. So we say that it's unlikely to be a type 1 error if we actually find a statistically significant difference. Now, if we do not find a statistically significant difference, meaning the p-value will be greater than alpha, then the results are negative. Now the question is it truly a negative result or is it a false negative? And false negative, we call it a type 2 error. And we have beta to for type 2 error. So typically we set beta as at 0.2 or 20%, meaning that we can tolerate up to 20% of type 2 error. And we use beta to calculate power. So the equation for power is power equals 1 minus beta. So for example, if we set beta to 20%, then the power would be 100% minus 20% would be 80%. And then we use the power to calculate how many patients we need in the study. So we do sample size calculation. So if the study does not find the difference between the two groups, so if the results are negative, we look at the power. So if the study is actually powered, we can say that it is unlikely to be a type 2 error. So therefore, there is no statistically significant difference between the two groups. On the other hand, if the study is underpowered and the study did not find a statistically significant difference between the groups, we can say that, well, while the results are not statistically significant, it could be due to type 2 error. So we need to do another study with more patients in it in order to have a powered study in order to find the statistical significant difference. And of course, we're talking about observational studies. So in observational studies, we can get the relative risk reduction, absolute risk reduction. We can calculate number needed to treat as long as the results are statistically significant and the outcomes are clinical, not surrogate. We can also have odds ratio. We can have R for correlation, and we can also have R squared for correlation of determination. And then we need to know how precise are the estimate of the risk. So we also need to look at the confidence interval. And then once we evaluate the results, then we need to look at the external validity to see if the results actually apply to the patients in our practice. So we need to see how similar were the patients in the study to our patients. That's when we look at eligibility criteria, which is the inclusion and exclusion criteria. And we can also look at baseline characteristics to see if the patients in the study were actually similar to our patient. And it's not to say that if your patient doesn't look like the patient that never the results apply. You gotta look at the patient and see, are there biologic differences in your patient that would result in differences in your patient outcome. And also in observational study, we need to see if the follow-up was sufficiently long. For example, most cancers take a decade or longer to develop from the original assault at the biologic level. If an observational study question is whether a specific exposure, let's say industrial chemical, is related to a subsequent cancer, one would not expect cancer detected in the first few years to reflect any of the effect of the exposure under question. So that kind of study would require, decades of follow-up in order to find that harm. And also we need to make sure that the exposure is actually what's going to happen in our patients. So that's when we need to pay attention to the dose and duration of therapy in this observational study, as well as the time period. For example, the risk of thrombophlebitis associated with oral contraceptive use in the 1970s may not be applicable to the patients in the 21st century because currently we have lower estrogen dose in oral contraceptives compared to the 1970s. So you should also take things like that into consideration. And of course, when you want to see if the results are clinically significant, you need to take into account the magnitude of the risk. We can use things like absolute risk difference, number needed to treat and number needed to harm for cohort studies only, but we cannot do this for case control studies. And that's because case control studies do not give you any information about prevalence. They only give you the odds. And of course, you should also consider risk versus benefit. So you must always use your clinical judgment, and you can also involve the patient in the decision making. This concludes this presentation.